Hello and welcome to the third installment of the Carlson Orthodontics podcast. It is August 2012, and today I'd like to cover a CBCT and dosimetry update. And given the advancements in technology and what we've been experiencing in the last 12 to 18 months, this will serve as a nice adjunct to the previous podcast. And what I'd like to do is just expand on that foundation information from the last podcast and explain what's been changing in CBCT technology, and most importantly, how we're looking at dosimetry given the reductions in exposure that we're seeing with more recent CBCT scanning. So for those of you that have tuned into the previous podcast, I wanted to give you a bit more of my background. As I've discussed, I practice in Mill Valley, California. I have a private orthodontic practice there, have been in practice now for approximately 15 years. And part of my time is also spent at the University of Pacific, Arthur A. Degoni School of Dentistry. And there I'm an associate professor. And we've been studying cone beam CT and three-dimensional imaging technology for quite some time. In fact, if you go back to the beginning of CBCT, when it was introduced in the United States, in 2001 we were already experimenting with building a virtual three-dimensional patient. And as cone beam was introduced, we began to improve on our modeling, and as you can see here, adapting two-dimensional views with three-dimensional imaging. And we started to build these three-dimensional patients even as far back as 2003. But most of you that are familiar with cone beam CT imaging at this stage know that most of our modeling is now at this very advanced stage, and the amount of patient exposure to acquire this digital model is extremely low. And that's what I want to talk about today. And just from the visuals that you're seeing, understanding all of the information that's present in these CBCT scans, there's no question that this is the future of orthodontics, in my opinion. And this is definitely where most diagnostic procedures will be most valuable, given the amount of information that we're now uncovering, again, with very low exposure X-ray scans. So to refresh you all a little bit on the take-home messages from the first two podcasts, we discussed the ICRP, which is the International Commission on Radiological Protection. The things to remember from that 2007 publication are that the ICRP recommends limiting our exposure to 1,000 microsieverts per year. And they also changed the tissue weightings, which really has changed our dosimetry publications. As you see here, most regular dental x-rays, and this is what people experience when they go to the dentist for what's called a full mouth x-ray series. And these are often taken once a year, perhaps once every 2 years. And it's typically taken using round collimation, which means the exposure level of the CBCT is well below that. Here you can see it's almost 1/2 to 1/3 of a full mouth series of x-rays. And that's using a full volume scan, as we were doing historically with CBCT. What's changed for us in our practice, and I think this is changing for a lot of CBCT practitioners, is the volume, the areas of interest that we're now scanning have improved, and the exposure for these areas of interest has really gone down. So if we look at a 16 by 13 centimeter scan volume, which for me in my practice will cover approximately 90% of my patients, 90% of my children's scans without question. The advent of a new scanning technology from the iCat Next Generation machine is now scanning this area of interest in approximately 4.8 seconds. It's something called the iCat Quick Scan, and this was not available at the time of the original podcast publications. So now with this 4.8 second scan, we're actually able to decrease our patient exposure to 45 microsieverts. It's going down to cutting that almost in half of what we used to do with the full volume scan. Now what's interesting is if we shrink that down to 16 by 10, which can still fit some patients and give us a very exceptional area of interest, which includes the temporomandibular joint and all of the dentition. The exposure for that is now 39 microsieverts, again considerably lower than where we've been previously. Now, for most of our progress scanning that we're currently doing in my office, this would be considered analogous to what we typically use a panoramic X-ray for. Now, this is an 8 by 8 centimeter, which encompasses the entire dental arch, including third molars and all root perimeters. And the nice thing with this 8.8 second scan is this is in fact only 27 microsieverts. You'll recall from the Ludlow publications that a panoramic scan is approximately 25 microsieverts, a digital panoramic scan. So the three-dimensional information that we're gaining, comparable in exposure to a panoramic X-ray, is without question more valuable to the orthodontist. So here, this is where we were with the 8.9 second scan, 74 microsieverts. And here now with a quick scan, we can get that down to 45 microsieverts, which again now is just approximately 1/4 of a full dental X-ray series. And if we're just simply doing a panoramic or a dental arch scan, that's considerably lower. Now compare that, of course, to the background dose exposure of 8 microsieverts a day, which we covered in the last podcast. And if you look at it just in terms of per capita of background exposure, the quick scan of 4.8 seconds is now very closely approaching that of the panoramic X-ray. And again, it's about 1/4 of the exposure for a conventional series of dental X-rays. If you look simply at the 8 by 8 scan, which again is what we're using for progress scanning in our office, it's just about the same as a panoramic X-ray. So we feel that this three-dimensional scan, especially with a comparable exposure to a panoramic, will far exceed the amount of information that we can get in a panoramic with much less confusion. Now I want to review a little bit about radiation exposure because this has been a very hot topic, certainly in our profession and I think in the media as well. And to put this in perspective, I want to discuss some statements from a few of the very important groups in radiation exposure. And this, of course, most people know the EPA, the Environmental Protection Agency. And this quote comes from their publication on this, which says, "Current evidence suggests that any exposure to radiation poses some risk. However, risks at low exposure levels, which is what we do in dentistry and orthodontics, have not definitively been demonstrated to cause risk." Here's another from the United States Nuclear Regulatory Commission, and they say, although radiation may cause cancers at high doses and high dose rates, currently there are no data to establish unequivocally the occurrence of cancer following exposure to low doses or dose rates, and low doses being about 100 millisieverts. Now, keep in perspective that we talked about the ICRP's 1000 microsievert limitation. And here they're saying low dose X-rays are approximately 100,000 microsieverts. So we are operating very well below what they consider a low dose. Another statement from the American Association of Physicists in Medicine, and they say risks of medical imaging at effective doses below 50 millisieverts for single procedures or 100 millisieverts for multiple procedures over short periods of time are too low to be detectable and may be non-existent. Now, keep in perspective that these numbers correlate to 50,000 to 100,000 microsieverts. and the ICRP limit, if you recall, is 1,000 microsieverts per year. So there's no question we're operating at very, very low doses compared to what many of these agencies would consider low dose. And we are operating at 1/100th of what many of these agencies would consider low dose. Now, the BEAR Committee is, again, a protection group that is focused on protecting the public from exposure. And the BEAR Committee has published a paper recently, and like the ICRP paper, this has a lot of very valuable information in it. And here are many of the talking points from that paper, but I will highlight the most important that stands out relative to this discussion, which is at doses of 100 millisieverts or less, statistical limitations make it difficult to evaluate cancer risk in humans. And that simply means that when we use the numbers from current science and attempt to extrapolate those numbers to doses below 100 millisieverts, it becomes impossible for the statistics to tell us the actual risk of cancer for human beings. To put that in perspective using a visual, this is the actual data graph from most of our dosimetry studies, and the low dose range that the BEAR Committee uses and most of these groups use is 100,000 microsieverts. Now, the ICRP is in fact 1/100th of that in terms of their recommendation of low dose. And with most of our CBCT scans, we are then operating at 1/10 of that 1/100th. So again, we are operating in a very, very low dose range where even at 100,000 microsieverts, most of these committees are saying that the calculable risk of cancer is unfortunately impossible. The American Association of Physicists in Medicine goes on to state predictions of hypothetical cancer incidence and deaths in patient populations exposed to such low doses are highly speculative and should be discouraged. Now, unfortunately, the media doesn't always take that comment to heart, and any risk, of course, garners lots of national attention. But to put this in a visual perspective of where current orthodontic imaging is relative to what we experience in ionizing radiation from background doses, here you can see on the bottom screen some typical orthodontic imaging protocols, a pan-ceph, for example, all the way up to a pan-ceph with 6 periapical x-rays. Now, if we were to take 3 series of orthodontic imaging protocols inside of 1 year and compare that to the annual background dose, you can see how even at larger exposure protocols, this is absolutely dwarfed by the effective dose of ionizing radiation that we acquire from just simply being alive. You can see at the 1,000 microsievert mark, there is the ICRP annual limit. And all of these imaging protocols, even if they were done 3 times in the same year, are still very well below what the ICRP would consider their annual limit. Now, all of the agencies that I just mentioned, if we put in perspective what they are considering low dose, which again is 100,000 microsieverts compared to 1,000 microsieverts, the imaging of orthodontics is absolutely dwarfed by what would be considered low dose. So again, I think most practitioners can feel very comfortable that the exposure rates in all of dentistry and in medicine, for that matter, are well below what science to date can tell us about any risk that humans may have from acquiring cancer from typical imaging procedures. So to review risk a little bit, this is the quantifiable likelihood of loss or less than expected results. And you guys saw this graph on the last podcast, but what I want to do is emphasize that bottom part of this graph where the CBCT is, which is approximately 15 minutes of LLE risk. Now, we looked at this graph on the last podcast as well, and I just want to review a couple of things about this graph given the updated changes in terms of the exposure. Now, this is looking at our exposure from a hypothetical cost of the risk, and here we used to be where the CBCT 3D x-rays cost us about 35 cents versus the typical pan-ceph of 17 cents. Now, with our decreased exposure, that risk is now costing us 21 cents. If the patient is relatively small and we can fit them into a 10 by 16 centimeter scan, that risk actually goes down to 19 cents. So quantification of that risk based on LLE is quite small. And if we look at it in perspective of our daily risks, incidentally, a can of diet soda is also associated with 19 cents of risk. So when we look at it in perspective of something like drinking a diet soda, it becomes a little bit more clear how low a risk we're actually talking about. So for an orthodontist who's been using this technology since 2008 to look at the three-dimensional image on the right and compare that with the data acquired from the two-dimensional set of orthodontic x-rays on the left, there's no question that the value of information from that model shown on the right far exceeds the relative risk associated with the x-ray exposure. There's no doubt in my mind that this is where the profession will ultimately be, and I think we're just beginning to touch on the advantages of having three-dimensional information compared to two-dimensional information. And as we move forward, there's no question that the research will catch up with the clinical data that we're actually seeing in our practices for those of us that have embraced the CBCT technology. We're really moving into a new era, and I think ultimately this discussion of dosimetry will be in the past. But some of us who have been involved in CBCT for a long time are beginning to question, well, why is it taking so long for this to take off? And to put that in perspective, I want to review a little bit of history of cephalometrics, which now most orthodontists sort of feel is the gold standard in orthodontics. Those of you who know cephalometric history know Holly Broadbent, who brought cephalometrics to the United States in 1931. The popularity of cephalometrics really didn't start to take off until later. And with people like Downs and Cecil Steiner, who you're seeing here, Cecil Steiner's paper, Cephalometrics for You and Me, really started to popularize cephalometrics. Now, this came in 1953, which was over 20 years after Dr. Broadbent introduced cephalometrics to the United States. To give you a sense of what the orthodontists were thinking at that time, this is actually a presentation given to the Angle Society by Dr. Steiner in 1959. And the beginning of his presentation starts like this. To those of you who are not fully employing cephalometric principles in your orthodontic practices, I ask you these questions. Do you really want to know what you are doing to your patients, or are you afraid to find out? Do you suspect that if you did know, you might sometimes be unhappy? And if you did not like what you found, would you do something about it? If the answer to these questions is no, then you don't need a cephalometer. Now, this is back in 1959, and cephalometrics was probably just as controversial as CBCT is now. I think when we look back on this period of time relative to CBCT, I think it will be similar to looking back on the beginning of cephalometrics, which this lecture by Cecil Steiner shows how much of a climb the early cephalometricians had when they first introduced cephalometrics to the orthodontic profession. Right now, we're just about 11 years in cone beam CT has been in the United States for just over a decade, and as an orthodontist, I'm certainly excited to see where we go in the next 11 years. And I think what we will see is an advancement in how we're clinically treating patients, how we're diagnosing, and the efficiency with which we do both will no doubt be improved. So thanks again for tuning in. Be sure to check back on iTunes or on YouTube for future podcasts. If you're interested in finding out more, please visit the carlsonorthodontics.com website.